Good morning, everyone. Bob Ravenscroft, Vice President for Advancement, here for our December 8th media briefing. We have a wonderful guest with us today. Katie Packard, works in our pharmacy here, is on the faculty at Creighton University. She's been on these briefings before, but she is going to almost take us all to school and begin educating us on the vaccine and our process for that. We're anxious. Katie will provide more detail. I know that we're planning a run-through on Friday to make sure everything works fine, but we are gearing up, anticipating the FDA approval. Real quickly, our midnight census was 508 patients. We have now tested almost 37,000 patients here at Bryan, resulting in 5,484 negatives. Pending results are only at 68, which is always an indicator for us that the outsourced labs are keeping up, which is wonderful news. The number of COVID-19 patients in the hospital right now that are still positive is 80. 46 of them are from Lancaster County and 34 of them are outside of the county patients. There's an additional 31 patients that are still hospitalized, but they're in that category of no longer infectious, but they were ill enough that they still cannot go home. Total in-house positive and pending, there's an additional 19 patients that we're awaiting results. That typically means they've come in since midnight and just not in the daily statistics. 62 of them are from Lancaster County and 37 of them are from outside of Lancaster County. Patients on ventilators, total it's 19. 9 of them are no longer infectious, and only 2 of these patients are from Lancaster County. In our ICU, we have 18 COVID patients, 10 that are no longer infectious, so 28 patients are occupying our ICU beds. Before I introduce Katie, there's been a lot of discussion about things leveling out. That definitely is played out in the statistics and commentary on not letting our guard down. I think that's the understatement of the year. When we look at our hospital stats compared to the rest of the state, in yesterday's report it had Bryan with 127 COVID-19 patients. That was 37 more than any other hospital in the state. So despite it leveling out, it's like we've said before, taking premature victory laps is not what we want to do with COVID, and it's still a very high census for COVID patients here. It's my distinct pleasure to introduce Katie. She'll do a little bit more introduction on herself, but this is going to give you all the information you want to know about the vaccination to date. She'll be back on Thursday for even more, but sit back, soak it in, and then we'll answer questions afterwards. There were a couple of advanced questions that are kind of incorporated into Katie's presentation. So I'm going to turn it over to Katie.
I am Katie Packard, and I am a pharmacist, and I am a professor at Creighton University, and I'm also the research pharmacist here at Bryan Medical Center. So to date, there have been over 14 million cases of COVID-19 infection in the United States and over 281,000 deaths. At the same time, the pharmaceutical industry, the U.S. government, academia, and global health agencies have collaborated on the development of vaccines at an unprecedented speed. Today, for the first part of this briefing, we will share some facts about the virus that causes COVID-19 disease, or SARS-CoV-2, which will illustrate why vaccines are so critically important. We will discuss what we currently know about the safety and efficacy of 2 of the vaccines that are currently underway approval for emergency use authorization by the FDA. For the Thursday press briefing, we will address some of the COVID vaccine 19 myths and answer frequently asked questions. One important difference between the SARS-CoV-2 virus, or the COVID-19 virus, and the influenza virus is how long a person is contagious before symptoms appear. For seasonal influenza, a person is generally contagious only 1 day before they show symptoms. For COVID-19, that period is longer. It can be 2 to 3 days. There are also differences in the time between being exposed and showing symptoms. This is called the incubation period. For seasonal influenza, the incubation period is about 1 to 4 days. For COVID-19, it is 4 to 5 days, but it can be as long as 14 days. Another important difference between seasonal influenza and COVID-19 is the number of individuals that a single person with the virus can infect. This is referred to as the R0 value. For seasonal influenza, that number is 1.3. For COVID-19, that number is estimated to be 2.5. This means that, on average, for every one person that is infected with COVID-19, they will affect another 2 to 3 individuals. This measure of contagiousness, or the R0 value, is important because it is used to predict what we call herd immunity. Herd immunity happens when a virus cannot spread because it keeps encountering people who already are protected against the infection. Once a sufficient portion of the population is no longer susceptible to the virus, then the outbreak theoretically stops. Experts estimate that in the United States, it will take 70 to 80% of our population, or more than 200 million people, to recover from COVID-19 in order to stop the epidemic from progressing. It is very important to understand that our healthcare system cannot possibly accommodate that many patients as we are experiencing right now. When we overwhelm our healthcare system, deaths will occur because of our inability to care for so many patients. That level of infection would also lead to a large number of patients with serious long-term outcomes and also millions of deaths. A better way to achieve herd immunity is through vaccination. On November 20th, Pfizer and German biotechnology company BioNTech applied for FDA emergency use authorization for the first vaccine for COVID-19. This application was based on data from their phase 3 trial in over 43,000 participants. The vaccine was found to be 95% effective. This means that only 8 people that received the vaccine contracted COVID-19 as compared to 162 that did not get the vaccine. Another promising vaccine candidate is being developed by the NIH and Moderna Therapeutics. They submitted their phase 3 data to the FDA on November 30th. This vaccine showed similar efficacy of 94.5%. In the approximately 30,000 participants enrolled, only 5 that received the vaccine developed COVID-19 infection compared to 90 that did not receive the active vaccine. Also shown in this slide is that both vaccines prevented nearly all cases of severe COVID-19 infection. This is an important point because severe COVID-19 is where we primarily see hospitalizations and death from the disease. While the side effect data is still under review with the FDA, the most common ones that were reported were injection site pain, fatigue, headache, muscle aches or joint aches, chills, or fever. Most of these side effects were mild or moderate, and they are similar to side effects from other FDA-approved vaccines. The side effects generally occurred 1 to 2 days after the participants received the vaccine, and they resolved in a meeting of about 1 day. This slide also indicates that a very small percentage of these side effects were graded as severe. Again, this is similar in frequency to what we see with some other FDA-approved vaccines. While there are other vaccine candidates in development, these 2 currently hold the most promise for rapid deployment in the United States. Both are mRNA vaccines and will require 2 doses. They are injected into the muscle of the shoulder, just like the influenza vaccine. The Pfizer vaccine is given 2 doses 21 days apart, and the Moderna vaccine is 2 doses 28 days apart. The Moderna vaccine must be shipped and stored at conventional frozen temperature range. The Pfizer product requires ultra-low cold storage. That means that it must be shipped on dry ice and then stored in a special ultra-low temperature freezer. It is possible that both vaccines will require additional booster doses at some point in the future after the first 2 doses. This is because we don't yet know how long immunity to COVID-19 lasts, either for a person who receives the vaccine or for someone who actually experiences the illness. Both vaccines are already being produced in advance so that the vaccine programs can start as soon as the FDA grants emergency use authorization. Pfizer has predicted that they will produce 50 million doses in 2020 and up to 1.3 billion doses by the end of 2021. Moderna has stated that they will have 20 million doses to ship by the end of 2020. The state of Nebraska is expected to receive over 100,000 doses of a combination of both of these vaccines by the end of this December 2020. Bryan Health was initially selected as one of 5 sites in Nebraska to receive the first shipments of the vaccine. But as shown on the map of our vaccine state plan, there are many others that will be receiving the vaccine and supplies. These will include hospitals, local health departments, public clinics, and the Indian Health Service. At Bryan Health, a multidisciplinary team has been meeting regularly, not only internally, but with local and state health officials and also with Pfizer, so that we are well prepared to deploy the vaccine immediately as soon as emergency authorization is granted. This decision can happen with the FDA as early as Thursday, December 10th. Emergency use authorization does not mean full FDA approval. The FDA commissioner may allow unapproved medical products or vaccines to be used in an emergency to prevent serious or life-threatening diseases such as COVID-19 when there is nothing else available. Bryan Health has experience with emergency use authorization products. For example, remdesivir, which is now FDA approved, and also currently with convalescent plasma. Emergency use authorization requires that vaccine recipients are provided with an information fact sheet in order to make an informed choice about receiving treatment. They are given the opportunity to ask questions, and they must provide verbal consent. Therefore, COVID-19 vaccination at this time is voluntary. Both the CDC and the state of Nebraska have comprehensive vaccination plans, which are often updated and available online as public domain. These plans guide institutions on how to prioritize the initial vaccine supplies. The plans are evolving frequently and updated as new information becomes available. They will also adapt based on the vaccine production and the vaccine demand. This slide summarizes the phases of the current state of Nebraska vaccine plan, and it's also available online. For Nebraska, Phase 1A recipients include healthcare personnel, including hospitals, emergency rooms, long-term care facilities, urgent care, primary care offices, and those in direct or indirect exposure to patients or infectious materials. Phase 1B broadens these criteria to high-risk individuals in the community, essential critical workforce such as teachers, food processing, and correctional staff. Finally, Phase 2, which is expected to occur later in spring of 2021, will include the general population. Bryan Health continues to work daily with local, state, and national partners to finalize our COVID vaccine plan so that we are ready to offer the COVID-19 vaccine to our Phase 1 personnel immediately once emergency use authorization is granted. We are in the process of educating our physicians and staff, and will bring the community the same information at our next press briefing. We will expect to get our first shipment as soon as the FDA provides emergency use authorization, which could happen as early as this Thursday. That will be the Phase 1 healthcare providers at Bryan Health. Again, this will include Bryan Health, but a little more broadly to include BPN and also urgent care providers. And again, that first priority will happen to those that interact with patients.
Well, how do you explain it? I think the communities around Nebraska are taking this more serious than ever. I think we've said before, Andrew, that we're kind of anxiously awaiting to see if anything happens from Thanksgiving get-togethers. That's always, you got that lag period of time. But I think, until Katie just presented on the vaccine information, until we have that, we don't really have many options. It is basically prevention at the community level. So the masking and distancing and all of the things we've talked about since March, April. I don't think the criteria of symptoms has changed that. Again, I think it's probably more prevention, is my opinion. Now you're onto something though, that there are more people receiving higher levels of care in critical access hospitals or in long-term care facilities or quarantining at home than maybe we would all like, and that's just because of how full the hospitals are getting. So it kind of backs up along the way. The one thing I would say about changing criterias, and Katie, if you have anything, just let me know to add, but we have gotten better with our treatment regimens and what we know about this since March. So
How we're planning to track individual employees here at Bryan Health if they have our first or second shot is internally through our employee health system. We already vaccinate all of our employees here annually for the influenza vaccine, so that platform is already available. In addition, the CDC is working on an app called vSafe, and this is still in development, so I'm not sure when it will be rolled out, but this is another system where the general public should be able to track when they've had their second vaccine. It will send them reminders, and they will also track adverse events that individuals can report to themselves through the app. So that's a second thing to look out for. A third mechanism, and I think it dovetails nicely with another question, where will people in other 1A groups, such as long-term care residents and staff, get their vaccines? So as indicated in that slide with the phasing, both long-term care residents and staff, it's been suggested that they are both included in the 1A. That was a recommendation made by ACIP about a week ago. And the federal government is partnering with community pharmacies, larger chains like CVS and Walgreens, in order to enter these long-term care facilities and help with the vaccination programs. Those large chain pharmacies have very sophisticated tracking programs to track the first and the second vaccine. So that's how we expect that will happen in those facilities and also to individuals in the public.
I can tell you what we're doing at Bryan. It will still be recommended for a period of time until we approach getting the right number of people in the community vaccinated. And obviously, we hope as many of our our employees that can or will have the vaccine available will take advantage of it. And in some of the stuff we're doing in our internal rollout, we do anticipate it's a high possibility that people will be masked for a long time, particularly if they do not receive the vaccination.
We will have to wait and see what the exact recommendations are based in the emergency use authorization provider information sheet, which we expect to come out as soon as EUA is approved. But here at Bryan, we are asking individuals who have had confirmed COVID-19 disease to wait 90 days until they receive the vaccine. So the answer is yes, we do want to vaccinate individuals who have had COVID-19 illness, because much of the evidence we're showing right now is that we don't know how long those antibodies last. The strongest evidence supports up to 3 months or 90 days. So while the vaccine is in very high demand and short supply early on, we're asking those individuals to wait 90 days. That answer was not addressed in the phase 3 trials for either the Pfizer or the Moderna. That wasn't the primary endpoint the point of those trials. So we truly don't know for sure once we are vaccinated if it could potentially be transmitted to another patient from getting COVID. Now, getting the vaccine itself does not transmit COVID-19 to other individuals. It is not a live virus vaccine. So if you obtain the vaccine, you are at no risk of transmitting. The question is, if you get COVID vaccine and then are later exposed to COVID-19 virus, could you potentially carry it or transmit? And that answer is not known at this time, but it is something that they are continuing to study as patients are continuing to be followed in these phase 3 trials.
Bryan routinely, for normal stuff, sees patients from every county in Nebraska throughout the course of the year, and in addition, surrounding states. Why we are receiving more, I think it's probably some of those entrenched referral networks, and then the size, scale, and expertise at Bryan. Certainly, the Med Center has that as well. But our reach into greater Nebraska is very robust and probably unrecognized or underappreciated, and I think that's the biggest reason is as you've been following, and I know you have, Matt, that for the longest time we were getting more people from outside of Lancaster County. Now that's kind of flipped, but that's probably the biggest contributing factor. One, because we can. Two, because of our historical referral networks. And three, the capability, high-end tertiary care that is afforded here is probably the big one. But when state numbers are grouped together, and we've had all of the percentages on when we shut down, when we open up, not shut down, but when we have more directed health measures, it's always been interesting to us because we've exceeded or approached those limits pretty consistently, and we've adopted to the best of our ability. So I don't know if that's a great answer for you, but that's the reality of it. We for the last month or so, I've been seeing more than anyone, and we're proud to care for people of the state that way. I think the death rate is heartbreaking, and I don't know if you call that alarming or heartbreaking. In fact, Nathan Albright, someone on our team, I think probably shares that instead of having these be numbers on the spreadsheet, he has created something that we like to look at a little differently, that the deaths are represented by stars in the sky over a skyline, and then you can hover over it and see how old the patient was and so forth. But it just seemed a much more respectful way to share that information internally than the numbers on a spreadsheet. I mean, I don't have it with me. Edgar, do you know what we're at now? The number of deaths today from? Edgar's going to get it, but in general, from March until the end of September, there were 20, 25-ish deaths here at Bryan. From then the month of October, there were another 25. In November, there were roughly 50, and December is doing the same thing. How do you reconcile that if you're a physician or a nurse seeing this every single day at accelerating rates? So I think the question is getting to, how does it make me feel personally? It's heartbreaking. And that's why we've been a broken record up here asking people to help us with all prevention measures, because it is not easy for nurses of all ages, physicians, depending on where they're at in their career. It is a very hard thing to deal with. Not only is it tiring and exhausting, but it's very real, and they're dealing with families, as that family member, essentially an extension of them when this is occurring. Edgar just held up a sign. We're now at 125 lives lost under our care here. Now, hundreds and hundreds more have been celebrated and returned home, but all 125 of them are someone's mom, dad, brother, sister, son, daughter. We've heard that before too. It is literally heartbreaking and frustrating when people call it a hoax and don't think it's real. I can tell you it's very real. It's an approximate. It's going to be approximately 3,000 initially.